The following podcast is part of a certified educational activity titled Upgrading the Sequential Therapy Toolkit for B-Cell Malignancies, New Evidence on the Individualized Use of Btk Inhibitors in Relapsed Refractory CLL, SLL, and MCL. Access the entire activity and complete the post-test at peerview.com/DQM860. Downloadable slides and practice aids are also available.
Good morning. It's great to see so many people here in person. It's quite a novelty to not be talking to a screen and talking to people in the room. It's fantastic. So thank you all very much for coming, and thank you to those online who are joining. My name's Toby Eyre. I'm a haematology consultant and honorary senior lecturer at the University of Oxford in the UK. And I'm delighted to be chairing this event with my friend and colleague, Dr. Anthony Mato from Memorial Sloan Kettering. And we're going to be talking about upgrading the sequential therapy toolkit for B-cell malignancies. So just as a way of introduction, I just want to kind of very briefly mention the available covalent BTK inhibitors that are approved both in the EU and in the US for CLL and mantle cell lymphoma. As you can see here, in the US, there's very broad approval for ibrutinib and acalabrutinib, as so in the EU. In CLL and SLL. Zanubrutinib has been approved in the US on the basis of the Sequoia study, and that randomized study has been presented, not published so far, but showed a benefit of zanubrutinib above bendamustine and rituximab. For mantle cell lymphoma, the approval is primarily ibrutinib in Europe, and then there's approval in relapsed disease for ibrutinib and the second-generation covalent BTK inhibitors, acalabrutinib and zanubrutinib in the second-line setting. And you can see here there are also non-covalent BTK inhibitors in development. Pirtobrutinib is undergoing studies in frontline and relapsed CLL and also in relapsed mantle cell lymphoma, so randomized phase 3 studies, and the results of those studies will determine the availability and use almost certainly of this agent in that setting. And there are other non-covalent BTK inhibitors in slightly earlier studies at present. So the approval of BTK inhibitors in CLL are really supported by a number of randomized phase 3 studies. You can see here a summary of these studies for ibrutinib, acalabrutinib, and zanubrutinib. Ibrutinib, of course, has been around the longest, and there's a number of studies supporting its efficacy against a range of intensities of immunochemotherapy, primarily in the frontline setting, so intensities such as chlorambucil, and then in younger, fitter patients, FCR, and there's benefit really across the board in terms of progression-free survival. And of course, the RESONATE study demonstrated a large PFS advantage over ofatumumab and led to approval in the relapsed setting. Acalabrutinib has been shown to be superior to again, immunochemotherapy, so obinutuzumab chlorambucil in the frontline setting, both as monotherapy and in combination with obinutuzumab. And then in the relapse setting, we'll see updated data actually of both of these studies in poster form at this meeting. There's continued superiority for acalabrutinib monotherapy over investigator's choice, bendamustine rituximab or idelalisib rituximab. And then I mentioned the Sequoia study showing superiority ahead of bendamustine rituximab for zanubrutinib. So if you look at the kind of current guidelines across Europe and the US, you can see in CLL, when patients require treatment, really regardless of whether they're fit or unfit or their mutational profile, you can see that BTK inhibitors really play a prominent role in the frontline setting in these disorders. So you can see ibrutinib or acalabrutinib is recommended in the frontline setting for a lot of these situations, along with venetoclax-based therapy. In mantle cell lymphoma, again, use of BTK inhibitors primarily sits in the second-line treatment setting at present. So the NCCN guidelines and the ESMO guidelines really recommend second-line use of the available covalent BTK inhibitors in this space. So BTK inhibitors really form a fundamental and key part of the management of CLL and mantle cell lymphoma. But what are the barriers to BTK inhibitor efficacy? Why do we sometimes run into issues with these agents? So this is pooled data from Jennifer Wyack, published a few years ago, really demonstrating that disease progression and adverse events, so other events for stopping ibrutinib, are the key drivers of ibrutinib discontinuation. This is pooled analysis over 4 clinical trials. Dr. Wyack also did a large analysis looking at reasons for ibrutinib-acquired resistance, and you can see here that the BTK mutations really form a very dominant part of the reasons for resistance here. So BTK mutations are seen in the majority, so alone or in combination with PLC gamma 2 mutations in the kind of combined majority of patients. And of course, the reasons for discontinuation do vary across the time points at which a BTK inhibitor is used. So if you look at the pooled data across 3 large ibrutinib studies, you can see this is published in Blood Advances now 3 years ago. Pooled data across the studies demonstrate that discontinuation rates are nearly 40% in these clinical trials, and progression and adverse events are the main reasons for discontinuation. And really, the timing of the usage of a BTK inhibitor determines whether progression or adverse events are the dominant factor. So you can see here, this is data from the RESONATE-2 study, so frontline ibrutinib use. There was 53% discontinuation overall, but actually adverse events were the dominant reason for discontinuation in this study. So different compared to, for example, relapsed refractory mantle or heavily pretreated CLL, where progression is more likely to dominate. What happens if you run through your main kind of standard of care options now? And by that I mean a covalent BTK inhibitor and a BCL2 inhibitor. Well, this is effectively defining a new unmet need in CLL, the so-called kind of double novel agent refractory group. And this is data from the US that Anthony presented at ASH last year. Look out for a couple of posters at this meeting that myself and Anthony are presenting as well, looking at this space. You can see here that the median discontinuation-free survival in this patient group, so time to discontinuation of a subsequent therapy or death, was only 5 months. So I think this really represents a new unmet need and a clear focus for the CLL treating community to look at. Mantle cell lymphoma, really a pretty similar and sobering story after covalent BTK inhibitors also. So this is actually historical data to some degree, but data demonstrating that actually in quite heavily pretreated patients progressing through a covalent BTK inhibitor, their survival is very short from a large global analysis and one from the US. So there's clearly an unmet need in this space. With that, I'll conclude the introduction. I'll hand over to Anthony next. I will just run through the agenda here today. So Anthony's going to talk about BTK use in relapsed, focusing primarily on relapsed refractory CLL. I'm then going to speak about sequential uses of BTK inhibitors in relapsed refractory mantle. Then we'll have some time for cases and then a Q&A. So without further ado, I'll hand over to my co-chair, Anthony Moto.
Okay, what a pleasure to be here. Thanks so much for attending our lecture, and today I'm going to focus on building a modern toolkit with BTK inhibitors specifically for patients with chronic lymphocytic leukemia. This is the latest on the use of BTK inhibitors in sequencing in CLL. It's really an exciting topic, and as you heard from Toby's excellent overview, there are 2 overarching themes that we would think about when we're thinking about selection of a BTK inhibitor. Number 1, does the drug overcome resistance in any way? And we'll focus on the evolving literature for known mechanisms of resistance. And then does it address the issues of intolerance that have largely been associated with the use of ibrutinib? Okay, so a few years ago, we would have had nothing to say for this section, but there is an evolving literature really helping us to understand the mechanisms of resistance. And as you can see from this slide, the most common reason a patient discontinues a covalent BTK inhibitor like ibrutinib is the development of a CYS481 mutation. These mutations render the drug ineffective. In addition, you can see downstream activating mutations at PLC gamma 2. There are other rare resistance mutations also listed on the slide that can emerge. And this is not a problem that's isolated to just ibrutinib. But what you can see from this slide is that these mutations, specifically the CYS481 mutation, can occur in the setting of other covalent BTK inhibitor usage, such as acalabrutinib or zanubrutinib. And so in summary, BTK inhibitor resistance contributes to disease progression in all of the covalent BTK inhibitors. So if you're resistant to ibrutinib, you're resistant to acalabrutinib, you're resistant to zanubrutinib. So here are the practical implications of resistance for treatment decisions. So number one, the evidence suggests that many CLL patients will progress on ibrutinib exhibit these mutations, and it's estimated that this occurs between 50 and 70% of patients. So when I see a patient in the clinic, they're progressing, I check next-gen sequencing. Most of the time, I will find these mutations. But for clinical decisions, mutational testing in this setting is not absolutely necessary. So for example, there's probably no real data to support that you have to assess for the mechanism of resistance when making a decision what comes next for managing a patient with CLL. However, this testing can provide additional information that can complement treatment planning, and we'll go more into that. So what are the strategies we can use to address BTK inhibitor resistance? And this will be a relatively short part of the presentation because there's not a lot of data to support many agents. And in fact, the only approved agents that we have available for treating this particular situation is Venetoclax. I'll show you the data in a later part of the presentation, but it's efficacious, but it can be complicated in terms of its administration, and it may not be appropriate for all patients. It's really exciting to share data for the non-covalent BTK inhibitors, and I'll talk about pirtobrutinib and nemtibrutinib and how these drugs can overcome the resistance mechanisms that I've already presented. I'll demonstrate efficacy and safety information as well. Let's talk about some other available classes of therapy to think about. The PI3K inhibitors, for example, have limited benefit in this population and also significant toxicity burden. So PI3K inhibitors don't work in this particular situation. They're toxic, and also they've never really been tested in this situation. Chemotherapy, same thing. We don't have a lot of information about chemotherapy sequencing after a covalent BTK inhibitor, for example. And again, just to overemphasize this point, if you're resistant to ibrutinib, the more selective covalent BTK inhibitors do not work. So don't think about switching from ibrutinib to acala or to zanubrutinib. Here I'll highlight the data for Venetoclax. This is the Murano trial. Everyone knows it. It's been presented many times. The randomized trial of Ven-R, which is a time-limited approach versus bendamustine rituximab. You can see the excellent progression-free survival, median of 53.6 months, and overall survival of 82.1% at 60 months. So this combination works. What's not listed on the slide is that there is really no data for time-limited Venetoclax-based therapy following a covalent BTK inhibitor. So we sort of extrapolate this data from the Murano trial to covalent BTK inhibitor-treated patients. There is a trial looking at Venetoclax monotherapy as a continuous therapy in a heavily pretreated patient population, all of whom received a covalent BTK inhibitor, mostly all ibrutinib used. You see 91 patients listed there. Median number of prior therapies is 4. Half the patients had a deletion 17p. The most important thing to emphasize is that the overall response rate to Ven mono here is excellent at 61%. And the median progression-free survival is approximately 24 months, so the responses can be durable. Whether it truly is 24 months or 53 months as compared to the Murano data remains unknown because we don't have data for time-limited tested in this particular patient population. Well, what about the non-covalent BTK inhibitors? This is a slide summarizing initially the preclinical data, but later I'll talk about the clinical data. There were 3 drugs in development in this space: Nemtibrutinib or RQ531, pirtobrutinib, formerly LOXO305, or vecabrutinib. All of the clinical data I'll talk about today is for Nemtibrutinib and pirtobrutinib. These drugs are preclinically and clinically active in patients who have a CYS481 mutation. And you can see there that there are differences between these drugs and the covalent inhibitors, and that's largely the mechanism of action. They're reversible, forming a non-covalent bond. They bond at a different site on BTK, largely responsible for the reason why these drugs are effective in patients who are resistant to the covalent inhibitors. This is a nice cartoon demonstrating ibrutinib, where it binds, and why CYS481 needs to be intact in order for this drug to covalently bind. And then on the right, you see pirtobrutinib has a different binding mode. It does not require CYS481 binding, so this drug should be able to overcome that resistance mutation. 3 years ago, we really had no clinical data. 2022, we have a wealth of data on this particular molecule. I'll present an oral presentation at this meeting discussing pirtobrutinib specifically in CLL. Here are data that I presented at the most recent ASH meeting looking at this molecule specifically in 252 patients, all of whom had discontinued a prior covalent BTK inhibitor, largely ibrutinib, with the most common reason for discontinuation being progression of disease. So these clinically resistant patients, you can see here the overall response rate was 68%. And from the waterfall plot, you can see nearly every patient had a marked reduction in lymphadenopathy, regardless for the reason of discontinuation of the prior covalent BTK inhibitor. And then those red hash marks at the bottom also indicate prior Venetoclax exposure, so the double refractory patient population. And just to hit the point home a little bit further, the BTK Cis481 mutation status is not predictive of pirtobrutinib benefit. So this PFS data are patients who progressed on a covalent BTK inhibitor, so they're all progressors stratified by the presence or absence of a Cis481 mutation. You can see those curves are overlapping, which largely supports the fact that when you're thinking about the use of a covalent BTK inhibitor, it's not absolutely necessary to document the presence of a Cis481 mutation. And then here we have subgroup analyses, which can be quite helpful from this Bruin trial. And the one that's highlighted on this slide is the BTK plus BCL2 population. This is the double exposed or double refractory patient population. The patients who and I'm sure Toby would argue, have no standard of care options available to them. Here you can see the overall response rate was maintained for this patient population, and I can assure you the responses are durable. Now I'll switch to Nemtibrutinib, another non-covalent BTK inhibitor, which has demonstrated activity in patients with relapsed refractory CLL, in patients with BTK Cis481 mutations. These data were updated by Jennifer Woyak at the most recent ASH meeting. Smaller number of patients receiving the 65 milligram dose, only 38. However, you can see the overall response rate was approximately 58%. And the other thing I'll highlight is that we do want to also look at the toxicity profile associated with these agents. I won't have more information on that later, but the discontinuation rate here due to adverse events is approximately 8%. And then again, just emphasizing the response rate was 58%. Of course, I talked about the data for the resistance mutations associated with the covalent inhibitors. There is an emerging literature now to try to understand mechanisms of resistance to the non-covalent BTK inhibitors. This is data published out of the laboratory of Omar Abdel Waheb at MSKCC, where we did look at the few progressors that we had on pirtobrutinib and try to understand the mechanisms of resistance. You can see we identified 5 new acquired mutations in BTK at the time of disease progression. So these are different than Cis481 and are likely associated with the binding of pirtobrutinib, clustering around the tyrosine kinase catalytic domain of BTK. And that's all I'll say about that for now. Now we'll talk about intolerance. You heard this from Toby earlier, that the most common reason for discontinuation of a drug like ibrutinib, and to a lesser extent the other covalent BTK inhibitors, is intolerance. AFib, arthralgia, bleeding, hypertension, infection. Those are sort of the lists that I think of in my mind when I think about the most common reasons why a patient would come off of a drug like ibrutinib. How do we overcome that? And the question to ask yourself, are the second generation inhibitors, are the non-covalent inhibitors any better in terms of adverse events that would make it more, would make it better for patients to be on those agents rather than the first-in-class ibrutinib? So you can see here the covalent or the irreversible and reversible inhibitors, Acala, ibrutinib, and zanubrutinib listed on top, and then Arcule or Nemta and Pirto listed on the bottom. They have different kinome maps, which can be associated with different specificity for BTK, but also differences in off-target effects. That's what we should be emphasizing here. And those differences might lead to some subtle or not so subtle differences in adverse events that we care about for our patients. So the less selective BTK inhibitors have more off-target effects, which may contribute to more toxicity associated with these agents. And so you'll see this theme over and over again, whether or not we're more selective for BTK and whether or not that translates into a difference. I don't really focus a lot on the kinome maps at this point in time. That's, again, preclinical data, less relevant when we have now head-to-head data that we can think about for patients. And here you can see 2 trials presented now approximately a year ago, looking at head-to-head comparison between ibrutinib versus acalabrutinib in the relapsed refractory setting. That's the Elevate-RR study, which is a trial that was selective for patients with poor risk features, either a deletion 17p or a deletion 11q. And while the drugs were shown to be similar in terms of progression-free survival with a non-inferiority design, the thing that we really pay attention to the most are the adverse events. AFib for Acala was 9.4%. 16% for ibrutinib. These were statistically significantly different from one another. I always look at reasons for discontinuation. I think that's probably more helpful. The AFib led to 0 discontinuations for Acala, but 7 discontinuations for ibrutinib. And then zanubrutinib was compared to ibrutinib in the Alpine trial. Totally different study design. ORR was the primary endpoint. I'm not going to talk about efficacy at all today. But what I would like to mention is that, again, you see a difference in cardiovascular toxicity. AFib or flutter was 2.5%, was 10.1% for ibrutinib, and these were statistically significantly different from one another. There's also subtle differences in other cardiovascular events, and I would urge you to pay attention to these 2 trials and take a look at those. I also want to highlight sequencing data for going from ibrutinib to a second-generation covalent BTK inhibitor. This is data presented by Carrie Rogers, where she went from ibrutinib to acalabrutinib. And the trial design was such: if a patient was on ibrutinib, they had an adverse event, they stopped the drug, we waited for progression. When they progressed, they switched to acalabrutinib. The overall response rate was 73%, 8% CRs or CRI. The responses were durable. The median was not reached. But what I'm highlighting on this trial is really the window into the differences in the adverse events associated with these drugs. You can see for the 5 events that are listed here, there were 41 patients who had a discontinuation of ibrutinib. You have to wonder, would these same events occur on acalabrutinib? Well, they did. They occurred 24 times as compared to 41, but 18 of the 24 were at a lower grade. 6 of the 24 were at the same grade. Only 1 was at a higher grade. So even in a patient population, all of whom discontinued ibrutinib due to an intolerance event, you can see that these events are occurring less frequently. And the one that is the big standout for me is AFib. 16 patient discontinuations due to AFib on ibrutinib, only reoccurred twice on acalabrutinib, and both were at a lower grade. Well, what about the non-covalent BTK inhibitors? I already mentioned a little bit about the AEs associated with nemtibrutinib, but what about pirtobrutinib? We know the drug is active, but what about the discontinuation rate due to adverse events? And can that give us some window into whether or not this drug is better tolerated than the covalent BTK inhibitors? The discontinuation rate for this drug due to AE was only 1%, but specifically looking at the intolerant population, just like I mentioned earlier, there's also evidence that this drug is quite active. The initial report had an overall response rate of 52%. Subsequently, this data has been updated to now have an overall response rate of 75% in the ibrutinib or acalabrutinib intolerant patient population. And then here again is the window into the cardiovascular adverse events associated with pirtobrutinib. The 2 things that I'll highlight are AFib or flutter, only 2%, very low. Hypertension, quite low at 7%. And then you can see the listing of other BTK inhibitor-associated adverse events. So the take-home points for my section of this presentation are that intolerance is the most common reason for discontinuation of a covalent BTK inhibitor. Testing for molecular resistance to a covalent BTK inhibitor is not indicated in clinical practice at this time. You can do it, it's interesting, I do it, but it's not needed for clinical decision-making. Following progression on a covalent BTK inhibitor, Venetoclax remains a standard of care. However, there are data emerging for the non-covalent inhibitors that are quite promising, although none of these are yet approved. And patients who are double refractory, those patients who are no longer able to benefit from a covalent BTK inhibitor or Venetoclax, represent the largest unmet need in CLL. And you'll see from many of our presentations and studies designed in the future, pay attention to this patient population. If a drug works here, it probably has a future in the field. And I'll stop there. Thank you very much, and pass it back to Toby, who's going to discuss the same issues in mantle cell lymphoma.
Excellent presentation, and a lot of the themes will be followed here as well, looking at sequencing of therapy with BTK inhibitors in mantle cell lymphoma. Much like CLL, the first-generation covalent BTK inhibitor ibrutinib and acalabrutinib, zanubrutinib, the second-generation covalent BTK inhibitors have been studied in pivotal trials in relapsed refractory mantle cell lymphoma. These are summarized here on this slide. What you can see here is that the ibrutinib-treated population is slightly higher risk in terms of the number of prior lines of therapy. You can see response rates across the board between 70 and 80%, broadly speaking. The CR rates between the 3 studies here are quite difficult to compare because PET-CT scanning was used in in the second generation BTK inhibitor studies, unlike the initial study with ibrutinib. You can see here low rates of discontinuation due to adverse events, as mentioned in mantle cell lymphoma. The context here is very different to, for example, frontline BTK use in CLL. And the progression-free survival here varies between about 14 months, and actually the updated data I'll show you in a minute is up to 33 months with zanubrutinib. But of course, it's very hard to kind of overly cross-compare against these studies, and certainly the efficacy is there with each of these drugs. Now, ibrutinib is approved in Europe, and each of these three agents is approved in the US. And the majority of use now is second-line therapy. And it's primarily because of this pooled analysis of ibrutinib-treated patients within clinical trials. So 370 patients across a number of studies have been looked at with ibrutinib monotherapy to see if patients particularly benefit from the agent at different lines of therapy. And you can see here that if you use ibrutinib at first relapse, you can expect a median progression-free survival of just over 2 years compared to under a year if you use it subsequently. And although there are some caveats to this analysis, you can see that there's potentially a survival benefit if you use the drug earlier, but of course you're not really comparing exactly the same kind of populations here in a more heavily pretreated setting. But nonetheless, this has really led to usage of BTK inhibitors at first relapse in mantle cell lymphoma primarily. Here's the acalabrutinib data from the ACE-LY-004 trial. So the median progression-free survival in this study was nearly 20 months, with an overall response rate of 81% and a CR rate of 40%. And again, this has led to approval and use in the US primarily. This is recently updated data of zanubrutinib, again in pre-treated patients. So this is data primarily from China. Response rate 84%, median progression-free survival, intriguingly, nearly 3 years. So interesting that this does seem to look like a slightly longer progression-free survival than the other BTK inhibitors, but whether that's a reproducible finding is difficult to be certain. And I think it certainly is another option for relapsed mantle cell lymphoma, and is again approved in the US for use. If you look at data, what happens to patients if they stop a prior covalent BTK inhibitor in mantle cell lymphoma? So this is data from the UK. So in the UK, NICE have approved the use of ibrutinib at first relapse only. So if we have a large population of patients who are all receiving ibrutinib at first relapse, and this is data looking at how patients do if they progress through through ibrutinib. And what you can see here, and this is a population of over 200 patients. If you have no further systemic therapy, now of course this will be due to either rapid disease progression or frailty and comorbidities. These patients have a very poor survival. If patients are fit enough for subsequent therapy, then they do a bit better. This primarily, though, is in the pre-CAR T-cell era, and R-BAC was the kind of one of the main, more intensive therapies that were used, and certainly showed that people did a little bit better. But I think if you take the population, still overall, the survival is very limited. So the overall median overall survival in this population was 1.5 months. So clearly demonstrating a need for development of new therapies in this space. Now, unlike CLL, where the mechanisms of resistance in a post-covalent BTK inhibitor are pretty clear and the story is much cleaner, actually in mantle cell lymphoma, the resistance mechanisms are much more varied. And for the purposes of time, I don't have a lot of time to go through all of this, but just to say that the mutations that are commonly seen in CLL are actually much more uncommon in mantle cell lymphoma, so represent really the minority of cases. And this represents an ongoing area of investigation, and again, we'll need looking at as BTK inhibitors move further up the treatment pathway. I mentioned CAR T-cell therapy. Brexacaptagene autoleucel is the licensed and approved therapy in relapsed mantle cell lymphoma based on the ZUMA-2 trial. I summarized the study here in this slide. You can see here that in this study, all patients that had prior BTK inhibitor, they were pre-treated with prior CD20 antibody, prior chemotherapy, So a representative population in that sense. And you can see here that response rates were over 90%, with 2/3 of patients achieving a complete response. And actually, this data has just been updated in the JCO, and very encouragingly, the patients who achieve a complete remission have very durable responses, including those with high-risk disease. So that's certainly intriguing data from that study. One of the major issues with this study, as well as the broader deliverability of CAR T-cell therapies, is the toxicity of this agent. You can see here that we've listed the grade 3 or more toxicities, and cytokine release syndrome, grade 3 or more is 15%. Most patients get grade 1 or 2, at least, cytokine release syndrome. And I think notable, really, the neurological events, over 30% grade 3 or more. Cytopenias and infections are also an issue. So whilst this therapy is clearly highly effective, it requires specialist care and an understanding of the adverse effects, and also management from a patient progressing through a BTK inhibitor and actually getting them to be apheres, the cells manufactured and delivered, is also a challenge. And so there are considerations when you're thinking in your clinic about who might be CAR T-cell fit and eligible. As I mentioned, the duration of response, progression-free survival, and overall survival is robust. This is the presented data from ASH last year, but this has been, as I mentioned, updated, and there's a poster at this meeting also demonstrating this data. So Anthony's introduced pirtobrutinib very nicely, so I'm not going to go over kind of a lot of the background of pirtobrutinib, just to really say that the Bruin study has investigated the agent in a number of B-cell malignancies. So CLL is the dominant population in the study, but also there's a large number of patients with mantle cell lymphoma. This is data, again, from ASH last year, and there's a poster at this meeting also discussing this data further. 100 patients have been previously exposed to a prior BTK inhibitor in this study, and the response rates are just over 50%, with CR rates of 25%. In the dark blue, as demonstrated here, are patients who stopped the prior BTK inhibitor due to progression, which represents the majority of patients in mantle cell lymphoma. And you can see here clear efficacy in this patient population. And if you do respond to pirtobrutinib, at the moment the responses are durable. So you see about half of people responding, and those that do respond, the median duration of response at present is about 18 months. Relatively short follow-up, and so we do need to see this data mature, but nonetheless this is very encouraging that there are patients who derive durable benefit from pirtobrutinib in this setting. That there are patients who stop because of discontinuation. So here in the light blue, you can see patients stopping for discontinuation due to toxicity. And these patients also have clear efficacy here with responses seen in this population. So again, this is potentially a useful agent in patients stopping a covalent BTK inhibitor because of toxicity. And Anthony's already gone over this, so just to briefly re-mention the toxicity profile. So really minimal toxicity in the way of cardiovascular events, some minor bruising, and some reversible and manageable neutropenia, but across the board. So this is the pooled data across over 600 patients, so a range of histologies here. But this is generally a pretty heavily pretreated patient population, and so this is certainly encouraging early data. The follow-up is relatively short, so we need to see this mature as well. But nonetheless, this is impressive data. What about other agents in terms of sequencing of therapy? So Anthony's already mentioned the data with acalabrutinib. There's also a small series of zanubrutinib-treated patients in those with B-cell malignancies who are intolerant or who are intolerant to either ibrutinib or acalabrutinib. These are the AEs listed, so these aren't numbers of patients, these are the total AEs, and to see whether they recurred, and you can see the majority didn't recur on zanubrutinib, particularly with the ibrutinib treated patients, or if recurrence occurred, it was generally at lower severity. So this is certainly encouraging data to suggest that zanubrutinib also is effective in those patients who are intolerant to ibrutinib. But this population is really dominated by CLL patients, so actually very few mantle cell lymphoma patients in this cohort. What about if you stop a covalent BTK inhibitor intolerance and you want to switch therapy, there's some data supporting lenalidomide-based therapy. There's a pooled analysis of pre-treated patients with ibrutinib, but these patients stop because of efficacy, lack of efficacy or toxicity. The response rates are about 30%, but these responses aren't particularly durable. So although lenalidomide represents an option, there are potentially other BTK inhibitors that may be available. And then just to highlight an ongoing clinical trial, this is, again, there's a poster at this meeting, and there was one at ASH, so do take a look at this. This is testing pirtobrutinib against investigator's choice BTK inhibitor. So depending on what's available in the centers of the investigators, ibrutinib, acalabrutinib, or zanubrutinib can be chosen. Patients are stratified by the simplified MIPI score, the BTK inhibitor that's being used, and the number of prior lines of therapy. And this is in a covalent BTK inhibitor naive patient population. So recruiting at the moment, and this is a superiority design study. And then just finally, really, to just briefly mention that this study, as mentioned, the Bruin trial actually is looking at pirtobrutinib in a number of other different histologies. And so there's efficacy activity in other diseases, particularly Waldenstrom's and Richter transformation. There's now a really quite a large cohort of patients being treated with this, so it'd be interesting to see follow-up data here. So the take-home messages really from this talk are that covalent BTK inhibitors are firmly established in relapsed mantle cell lymphoma, with the data primarily supporting their role as first relapse therapy. And although you do see long remissions occurring, particularly in those who achieve a CR at first relapse, continuing patterns of resistance are apparent. If you look at the literature that exists after BTK inhibitor therapy, the outcomes are generally very poor. But CAR T-cell therapy certainly is now a new standard of care option here, and certainly does change the natural history of the disease in this space. Non-covalent BTK inhibitors, particularly pirtobrutinib here that I've shown you, is certainly promising and may also add to the treatment options in the future. Okay, great. So what I'm going to do here, we've got a CLL case and then a mantle cell lymphoma case. So I'm going to present this case and then ask Anthony's views on this case. So this is a 70-year-old lady who had treatment-naive CLL. She had relatively few comorbidities, so well-controlled hypertension is the main one. So a pretty fit lady in her early 70s, and has unmutated immunoglobulin gene CLL, no TP53 mutation seen on NGS. And these are her blood counts. So you can see here that she's anemic, thrombocytopenic, has a white count of 200. She's got an enlarged spleen, but is pretty fit and has a reasonable creatinine clearance. So she's treated with acalabrutinib frontline. So this is obviously based on the Elevate treatment-naive study where acalabrutinib received frontline license. She responds. She then progresses after 3 years. So I suppose my questions to Anthony here, firstly, is you alluded to in your talk that you do test for it. So how frequently do you test for BTK mutations in these kind of patients, and what do you do with the information?
So at our center, we have next-gen sequencing available for testing in the setting of resistance. I tend to test it out of curiosity. I'm just trying to learn sort of what the resistance patterns look like. Although, based on current approvals, whether a mutation is present or absent, standard of care for me for this patient will be Venetoclax. But 50 to 70% of mutations are, 50 or 70% of patients are progressing in the setting of a CYS481 mutation. That's not 100%. And so I do think there is something to learn about other mechanisms of resistance. And so we do test. For the Pirto data that I presented, we would have not learned anything about mechanisms of resistance if we didn't test and learn. So kind of in that period where I think we're still gathering information.
Sure. So we've obviously discussed about the prevalence of resistance in terms of the resistance mutations. And as Anthony has mentioned, this is a kind of sort of learning tool. It doesn't maybe necessarily change decision-making at present, but it may be complementary for future treatment planning. So you mentioned Venetoclax. Any other treatment options you consider in this particular setting?
With approved agents, I think Venetoclax is really the only option for a patient like this. I think the PI3K inhibitors, at least in the real world data you and I have published many times over, they don't work well. The PFS is like 4 to 6 months, so that's probably not an answer. And we know from many clinical trials that the discontinuation rates are high due to adverse events, so I don't think that's the standard of care. I'm most excited about sequencing patients to non-covalent BTK inhibitors. We've enrolled, I think, between the two of us, so many patients on the Bruin trial. I kind of feel like it's a standard of care option in my practice, but of course it isn't. It's not approved. So we're using it in the context of clinical research, but we don't have it available should we want to prescribe it. So I would say non-covalents are emerging as an important class here, but Venetoclax, I think, would be the standard of care.
And Anthony, what do you tell your patients about what to expect from fixed duration Ven-R in this setting after a covalent BTK inhibitor? Do you feel comfortable extrapolating the Murano data to this kind of setting? Do you tell them anything different?
It's a good question. I don't feel fully comfortable extrapolating that data. So the Murano trial had a median of 1 prior therapy. So many patients who get Venetoclax in the relapse refractory setting are more heavily pretreated. That's one, although not this particular patient. I don't know the exact percentage, but it's like approximately 1% of patients on Murano had seen a prior covalent BTK inhibitor. So they're essentially an all chemo population. And while the PFS for Ven after ibrutinib was 24 months and Murano is 53 months, the data that I presented for Ven after ibrutinib was also in a more heavily pretreated population. The median number of prior therapies was 4. So I don't think I can, very accurately say what the median PFS is. And for anyone who's doing a clinical trial with Ven-R as the control in a modern population, I mean, it's quite difficult to try to estimate what the median PFS would be as a control. So I think there is some uncertainty there. It probably doesn't perform as well.
Sure. Okay, so I mean, I think we obviously kind of didn't talk specifically about this, but I think it'd be fair to state that there are no other covalent BTK inhibitor options that are appropriate if you're resistant to a covalent BTK inhibitor, and Anthony's been through these options, so Venetoclax plus or minus a CD20 antibody, certainly if you're giving us fixed duration with a CD20 antibody, so with rituximab, non-covalent BTK inhibitor trial, or a PI3 kinase inhibitor, although, as mentioned, pretty limited evidence for that. Okay, so this patient receives rituximab and Venetoclax, according to the Murano regime, and progresses 2 years after the end of therapy. So they responded, they had a 2-year remission, so off therapy for 2 years. What are your treatment options here? What would you go for? Would you re-challenge with Venetoclax? Would you use another agent? What are your thoughts?
First thought is this lady has bad luck because the Acala didn't work as well as it should have, and the Venetoclax didn't work as well as it should have. So this person is in trouble. If I had access to Pirto, I would do so at this time point, potentially as a bridge to other therapies. If she's really in good shape, she could be a candidate for CAR T study in the future or allo transplant. If I didn't have access to pirtobrutinib, I would re-challenge with Venetoclax. We have data that we'll publish soon together on Venetoclax retreatment in this situation, and it's active and you can see durable remissions the second time around, so that's something that you could think about. So my preference would be a non-covalent BTK inhibitor here, which can induce very durable remissions with or without a cellular therapy, if not Venetoclax.
Yeah. And any experience or data that you know of with immunochemotherapy, if you've got a dual-exposed patient like this? Have you seen any data, any experience?
We had a series, again, that we published a lot together, so it's probably fitting that we're doing this presentation together, that we looked at Ven-treated patients, most of whom had also seen covalent BTK inhibitors, and there was a small number of patients who had chemoimmunotherapy. The data didn't look very good. The median PFS was under 6 months. So I think once you've become resistant to Venetoclax and maybe even BTKIs, there's probably not a tremendous role for chemo, even if you're chemotherapy naive.
Great, thanks. And this is really just to highlight again that the patient falls really into this patient population. Of course, a lot of these patients in this specific setting actually would have had prior immunochemotherapy before, but nonetheless, you can see here the kind of new unmet need in this setting. Okay, and just to really highlight what Anthony said, so current treatment options are pretty limited. You wouldn't want to necessarily re-expose to to a covalent BTK inhibitor. I'd actually sort of change that statement that venetoclax is unlikely to be effective. I don't think that's necessarily fully correct. If they've had prior venetoclax rituximab and responded, I think it's a very reasonable option here. But certainly looking at clinical trials and looking for non-covalent BTK inhibitors looks reasonable. And as Anthony mentioned, PI3 kinase inhibitors have pretty limited efficacy and substantial toxicity here. And just to highlight that there are ongoing studies looking specifically at venetoclax retreatment. So this is an example. There's an example from the German CLL study group as well, but this is the Revenge study, which I rather like the name of. This is looking at retreatment of venetoclax plus obinutuzumab in patients who've received it at first line. And interestingly here, slightly different therapy lengths based on how long your remission to frontline venetoclax is. And of course, there's an open question as to how valuable retreatment with venetoclax is according to the duration of your prior response. So this will be an important and interesting study, and Matt Davids is leading on this study.
This is case 2, Max, an older patient receiving chemoimmunotherapy followed by a covalent BTK inhibitor. He initially presented with mantle cell at the age of 73, no major comorbidities, Ki67 was 50%, good performance status. Initial symptoms included weight loss, fatigue, and splenomegaly. So in terms of the treatment history, he received R-CHOP. He was not interested to consolidate the response with an auto transplant. Again, he experienced weight loss, abdominal pain at 3 years following R-CHOP, which is fairly typical, I would think. PET scan shows disease in the chest and abdomen. So he initiates single-agent ibrutinib at a dose of 560 milligrams daily. However, progression of disease was noted 1 year on therapy with ibrutinib. He's now 77. Performance status is a little bit worse than it was before, 1 to 2. So Toby, how would you characterize this patient and decide on next steps? Is he relapsing with an aggressive or resistant disease? Do you think he's a candidate for CAR T now? And then what are the other options that would be considered? Did I do okay presenting mantle cell? I haven't done that in a while.
I mean, I suppose this represents a fairly typical case, something that we tend to see. Mantle cell lymphoma patients are generally older, often have comorbidities, and so this is not atypical. In terms of the question about is this patient relapsing with aggressive or resistant disease? Well, I think his kind of clinical pathway demonstrates that he has difficult to treat mantle cell lymphoma. Certainly, if you look at some of the higher risk patient characteristics in terms of things like Ki67, blastoid disease, TP53, they often have a limited response to ibrutinib. So progressing after a year on ibrutinib is relatively short at first relapse. Is he a candidate for CAR T-cell therapy? I mean, I think that is the key question here. And he is, what I would say, very borderline, 77 borderline performance status. I think the currently approved CAR T product that we have would be a real challenge for him. I wouldn't necessarily wholly exclude it. It would slightly depend on on the availability, social support, what he wants to do, et cetera, all of those other factors which are clearly very key in terms of decision making. But he's certainly not a kind of home run in terms of CAR T-cell therapy, I don't think. And so other therapies available, difficult. I mean, he had a response to prior chemotherapy. You could go to a kind of attenuated bendamustine rituximab regime, but I wouldn't be particularly optimistic about the length of response. Certainly look for clinical studies as well here.
Could I add one more question to this? So if he has a high Ki67 for mantle cell, if he had some other poor risk feature like a del-17p, could you go off label and just say, would you consider BTK inhibitor as a frontline for this patient?
Yeah, that's a very interesting question. I don't think we have kind of very clear data that patients derive that much more benefit from p53 deleted mantle in the frontline setting. Obviously, we've just had the SHINE study published and presented. There is a relatively small cohort, but a cohort of patients with deletion 17p and TP53 mutations particularly do look like they do a little bit better with ibrutinib plus bendamustine rituximab, but it's relatively small numbers, difficult to make too much of that. At the moment, of course, it's not approved, and so we'll have to wait and see. But it may be a group that people move towards novel agents or potentially CAR T-cell therapy in the frontline setting in clinical trials.
So the other thing I wanted you to add here was potentially discussing how PIRTO might fit into your sequencing algorithm. And I guess in a world where this patient has a CAR T product sitting on the shelf waiting for them and the Nemtibrutinib available, how would you make the decision, and would you automatically sequence to the CAR?
Yeah. It'd be nice if the CAR T cell product was sitting on the shelf. Actually, one of the issues here is actually when people progress through ibrutinib in this kind of setting, their disease is often pretty explosive, and actually time from apheresis to CAR T cell delivery, et cetera, is really relevant and important. Yeah, if PIRTO was available, I suppose in the kind of CAR T cell unfit patient population, or those who are potentially quite borderline for CAR T cell therapy, pirtobrutinib is certainly, represents potentially an effective and safe option. Certainly something I'd discuss with patients if it were available. Absolutely.
All right. So let's now talk about this patient. So responds to the ibrutinib but experiences toxicity. So this is now the ibrutinib intolerant mantle cell population, which is probably the second most common reason for discontinuing ibrutinib here, right? It's more progression of disease. Develops AFib, hypertension, leading to discontinuation despite dose holds and adjustments, so you did everything you could. Now would you discuss next steps here for covalent versus non-covalent in this particular situation? How would you decide which agent would you use and why? And does a cardiovascular specific AE really factor into your decision making?
Yeah, it's a great question. I mean, I think to kind of answer this question, it would be very dependent on what you had available. So, of course, I mentioned that the approval of the different BTK inhibitors does vary across countries, and so in the US there's a fairly broad approval, but out in the EU at the moment, you can't access the second generation BTK inhibitors. I'd also say that the data on sort of sequencing with intolerance is primarily in CLL patients. So I think you'd be at least extrapolating that data, probably reasonably. I think I'd want to know how long the patient had been on the ibrutinib for, and just to check there were no signs of progression. I'm assuming from this case it's been on the ibrutinib a relatively short period of time, so you'd expect covalent BTK inhibition sort of sensitivity. I think that's obviously a key thing here. So depending on all of those factors, yes, I would go for acalabrutinib, zanubrutinib where available. Zanubrutinib has particularly low atrial fibrillation rates, and so if the AFib was a real issue, that would be potentially a very nice option. If not available, then a non-covalent BTK inhibitor in a clinical trial, and if none were available, again, we're back to the same scenario of potential CAR T cell therapy.
And just one other question then, since you brought up that lenalidomide data, do you think if you didn't have let's say the AE were particularly risky, major bleed or something like that.
Sure.
Would you then consider len to be the standard here, or what would you do?
Yeah, I mean, I think it represents an option alongside, treatment like bendamustine rituximab at attenuated doses or something. I think the lenalidomide data in this particular patient population is not particularly effective.
Okay. And so one other thing I wanted to add here was because it was mentioned in the case that everything was done appropriate, like in terms of dose holds and adjustments, agnostic of mantle cell or CLL. Can you just kind of add your thoughts about that strategy, and is it particularly effective for any particular AE?
Yeah, I mean, I suppose that's quite a large topic in itself, managing toxicities on ibrutinib. But yeah, absolutely. I mean, I think one of the issues with AF, of course, is that often patients then require anticoagulation, and that kind of potentially increases the risk of bruising, bleeding. They need additional medication to manage it. I think we've gained a lot of experience of managing patients with hypertension and AF on ibrutinib. Most people can actually be managed on it, but there are occasional patients that sort of decompensate when they get atrial fibrillation. I think that would be the thing that would really kind of sort of make my mind up for me in terms of switching. Or if they had very difficult to control hypertension, needing 2-3 agents at high doses, that kind of thing. Because it's clear that the rates of AF and hypertension are different with ibrutinib to the second generation BTK inhibitors.
And then I guess one other point to make from this case, we started at age 73, we're now 77. Can you just speak a little bit to the AEs associated with CAR T for any patient, but particularly an older patient, and how you're thinking about those AEs when deciding for oral therapy versus cellular therapy?
Yeah, so I suppose the key initial toxicities with CAR T-cell therapy are of course cytokine release syndrome and neurological toxicity, so kind of ICANS. The rates of grade 3, as I mentioned, the rates of grade 3 or worse ICANS are over 30%. If you look across the kind of CAR T-cell literature, the rates of that particular AE are probably more common in older patients as well. But not only those two issues, actually beyond that time point, there are issues with cytopenias and hypogammaglobulinemia, infection. They're all considerations. But also, I think in older patients, the kind of social setup and the requirement perhaps to travel away from their local center to have this therapy also is a major consideration for some people. And so all of these things really kind of come into the decision making.
And then just to add to the mix, I didn't ask you about Venetoclax, but I know there is not an approval for that, but there is literature that looks promising. So how would you use that here?
Yeah, so as you mentioned, Venetoclax isn't approved in this setting. There's some efficacy. So we published a really quite a high-risk UK series where Venetoclax was available on compassionate use. The response rates were about 50-60%, but they weren't durable. So the median progression-free survival in that study was about 3 months. There's some data from the MD Anderson, again, demonstrating efficacy, slightly longer progression-free survival. It has efficacy. Of course, it's being studied in combination with ibrutinib. The Simpatico study has completed enrollment, hasn't read out yet. And so that might be where Venetoclax is potentially used in a licensed setting. But in terms of the kind of post-BTK setting, it's off-label. It is used a bit. You still need to be careful about tumor lysis syndrome and so forth. All those aspects are still important, but the data demonstrates relatively limited efficacy. Okay, great. So thank you very much for your attention. That concludes the kind of main sections of this meeting. We've got some time for some audience questions. If we have some, and I think we've also got some questions online. So I'm going to move over and sit next to Anthony, and we're going to look at some of the online questions. But do come to the microphone, state your name and where you're from, and we'll answer your questions. So thank you for your attention.
So how are you going to treat those 11 patients that started their BTK journey with non-covalent when they progressed?
Yeah, that's a great question. So I suppose the first part of that question, obviously within the clinical trial, the majority of there were different arms in the clinical study, and there was an arm for BTK. There was almost kind of like a basket arm where you could treat mantle cell lymphoma if they were BTK naive. As you say, the vast majority of people have had a covalent BTK inhibitor. The randomized trial will sort of dictate whether kind of the second answer to your question in terms of whether PERTO will be used ahead of covalent BTK inhibitors in relapsed mantle cell lymphoma. And it's the control arm in that study is very relevant, and so it's asking an important question. In terms of sort of sequencing therapy the other way around, I think it's a very open question, to be honest, at the moment, across all B-cell histologies, not just mantle cell lymphoma. And we'll have that question really be asked, no doubt, many times of CLL patients who are receiving pirtobrutinib, who then develop progression and do covalent BTK inhibitors work there. I think there'll be a lot of work that will need to be done looking at resistance mutations and analysis in covalent BTK inhibitor naive patient populations as we move forward. There are studies, of course, of pirtobrutinib in combination who will be covalent BTK inhibitor naive, so it'll be really important to look at kind of the longitudinal data there to see whether there are responses to covalent BTK inhibitors, and B, what the resistance mechanisms are to pirtobrutinib in covalent BTK naive patients. Because Anthony's data from the New England Journal this year is excellent and really helpful, but it's not in a covalent BTK naive patient population, and that will be another important group. That CLL, mantle cell lymphoma, I think will be even potentially more complex than that because of the resistance mechanisms to BTK inhibitors there. But it's an important question, one we need to understand. Okay, we've got another question, and then we'll go to some online questions.
Okay. My name is Samir. I'm from Brazil. I wanted to ask you about the lenalidomide. When you mentioned about Venetoclax in the relapsed refractory mantle cell lymphoma, how do you compare if we don't have access? We have very few clinical trials open in Brazil when we don't have CAR-T. And is there a pattern of patients in mantle cell lymphoma with relapsed refractory, like blastoid forms, that may be more sensitive to lenalidomide or venetoclax in this scenario?
Yeah, that's a good question. So the data that exists in the post-covalent BTK space is kind of sort of, it's a pooled analysis of some trial patients, some real-world patients. The response rate is 29%, and the median duration of response in that cohort, I think, is about 20 months. So I think that's kind of what you can expect from lenalidomide. My sense is that the more proliferative your disease, the more difficult lenalidomide is to deliver in terms of getting control of mantle cell lymphoma. But I mean, that's pretty much true of most situations. Bad patients, bad disease biology kind of is difficult wherever you use agents. So yeah, I think in some of the kind of more indolent settings, it can be useful. Obviously, there's some very nice data in the frontline setting of R-squared, with R-squared, but I would not be too optimistic about how patients would do using len post-BTK.
Would you re-expose the patient to bendamustine?
I think there's very little data well, I suppose the case had prior R-CHOP, but if you've got somebody with who's had frontline bendamustine, and then your post-BTK, I think if they're fit enough to have bendamustine again, I'd really be thinking about CAR-T cell therapy if it's available. If it's not available, I think I'd probably go on the sort of duration of your prior immunochemotherapy response, but I'd still be tempted probably to switch and use, for example, an anthracycline-based therapy or something if chemotherapy were your kind of only option in that setting. Okay, we've got another question from the audience.
Hello, good morning. I'm from Argentina. Thanks for the lectures. We know that Btk has responses after double-refractory CLL patients and mantle cell lymphoma patients who have received CAR T cells. So the question is, it's going to be after covalent Btk inhibitors refractory approved, that shouldn't they leave it after BR refractory patients or CAR T cell refractory patients?
So for mantle cell lymphoma?
I could ask in both settings, I think, are not bad. I prefer to deepen in CLL patients since in Argentina we haven't got CAR T cells.
Yeah, Anthony, do you want to answer that?
So I guess so you're asking, should pirtobrutinib be saved for last? Is that basically the question? Yeah, I don't think so. To begin with, in CLL, there's data now to suggest that the drug works quite well in patients whether or not they've received Venetoclax, but I'm still of the mindset to try to stay within a pathway. So like the extreme example might be some patient who got ibrutinib, was intolerant, went to acalabrutinib, was resistant, went to pirtobrutinib, had a durable remission, but then progressed. There's data that we presented at the ASH meeting last year, Megan Thompson, a fellow at MSK, to suggest that Venetoclax remains active in that situation, and we'll expand that data hopefully this year. So I think from a sequencing perspective, you don't, at least with the real world data, and I wish I could quote a clinical trial, but they're just not being conducted in this situation, that Venetoclax would work here. Whether or not you should go to CAR-T prior to pirtobrutinib, I think is harder in CLL to answer. First of all, we don't have an approval, and it's always the balance of whether or not the CAR should be moved up earlier where the T cells are likely effective still, or to be safe for later. So I think that's completely unknown. I go with ease, honestly. It's easy to start an oral therapy for the most part.
Indeed, CAR-T I meant.
Oh, okay. So I'm assuming, yeah.
So
Would have responses after pirtobrutinib in CLL, and we should leave it after.
Well, the Bruin trial, like most clinical trials, doesn't have sequencing data upon progression events, but we are collecting data together on progression events and looking at next therapies, and we do have data on a small number of Ven-treated patients, which the number will expand in size, to suggest that you can sequence ven after pirto, and it's still active.
In terms of your question about CAR T-cell therapy or PIRTO in mantle, I mean, I think it's very dependent on the clinical context and the fitness of your patient and availability of CAR T. I think, clearly the case I presented, there's a kind of nuanced discussion you need to have with the patient about an available, pretty non-toxic oral agent with response rates of 50% versus more toxic, more involved therapy that may involve travel, et cetera, with responses of 90%. And I think if someone's fit for CAR T-cell therapy at the moment, CAR T represents the standard of care option, and certainly the updated data that's being presented is very encouraging for those who obtain a CR. So that would be the discussion I'd have with the patient. Of course, as patients get older and more frail, obviously the kind of oral non-toxic option becomes that much more attractive. And the fact that it's non-toxic as well in terms of cytopenias, infections, etc., also lends itself potentially to the post-CAR T space, which is actually a difficult space to deliver therapy in as well. So I think that's where we may see kind of use in the future, pending approval. Okay, well, if there aren't any more questions from the audience at the moment, do come up to the microphone if you do have any. We've got a couple of questions. We've got a few questions online. So there's a question here just to kind of add to my point about CAR T-cell responses correlating to Ki-67. And if you look in the recent I suppose the question really is, do you see responses there? The answer is yes. There's some data from Zuma-2, but also data from particularly the US kind of CAR T consortium, demonstrating that actually certainly initial responses are pretty independent of high-risk features in mantle cell lymphoma, which is certainly encouraging. And as I mentioned, actually, that the longer follow-up, the kind of 3-year follow-up of the Zuma-2 study demonstrates that the higher-risk patients do actually, if they achieve a CR, do have durable responses. Yeah, Anthony, do you want to answer? So there's a question here on, is there any early data of time-limited combination therapy with non-covalent BTK inhibitors and Venetoclax?
Yeah, so the Bruin trial did have 2 exploratory arms that were added to it. One was looking at the combination of pirto plus ven, and one was looking at the combination of pirto plus ven-R, both of which were presented, at least the early data, at the AACR meeting by Lindsay Roker, which looked to be quite promising in terms of the adverse event profile and also the activity seen so far, very high overall response rate. That has led to the randomized trial, which is a phase 3 trial looking at ven-R plus or minus pirtobrutinib in a very relevant population. It's a relapse refractory study, 80% of whom had seen a prior covalent BTKI, which is very different from the patient population who participated in Murano, with the opportunity to change the standard of care for a triplet versus a doublet. So that's, I think, probably the most advanced study right now. There is a phase 1 trial looking at I think it's LOXO-338, I'm forgetting the number, the BCL2 inhibitor in combination with pirtobrutinib, which is just getting underway. So sort of different BCL2 inhibitor in combination with pirto, but absolutely no data on that available at this time.
Thanks.
Okay.
Okay, we'll do one final question. So there's a question here about how you manage TP53 mutated mantle cell lymphoma patients, and is ibrutinib plus venetoclax a treatment option? So it's obviously a highly active combination. We've seen that from the AIM study, so that a publication from the Melbourne group demonstrating really high responses. Actually, within that subgroup, there are some patients with P53 mutated disease that do obtain complete remissions, and the responses look durable. There are a number of studies. Don't have time to go into all of them, but actually, analyzing this combination with or without CD20 antibody in the frontline setting, and there'll be P53 mutated patients, no doubt, within that population. And of course, there's been the Simpatico study, which we're awaiting the results of. So I think all of those newer studies will give us a better idea about what we can expect with BCL2 BTK combinations in the future. But I think if you had the combination available and you could use it, despite the fact it's not approved at the moment, yeah, it's an attractive option within clinical trials and so forth. And thank you again for your attention, and thank you for joining us today.
This activity is certified by PVI, Peer Review Institute for Medical Education. Remember to download the slides and practice aids. Thank you for listening. Download materials and complete the post-test for instant credit at peerreview.com/DQM860. This activity is supported by an educational grant from Lilly.